Good afternoon, everyone in the UK, and good day to everyone else from abroad. This is the first virtual conference that the BSMT has organised. Obviously, in unprecedented times, it's difficult to get people to face-to-face meetings, but it has had the benefit that we've been able to attract many people from abroad. And we've got representation or participants from at least 70 countries. So it's truly an international meeting. Normally, the chair of the BSMT would welcome you to the meeting. Chair is Valerie Bevan, but she's asked me just to say a few words as past president of the BSMT. First of all, we'd like to thank the BSMT committee for arranging this meeting. And we'd like to thank our commercial sponsors for their support. Without their support, we would not be able to hold these meetings. And as past president, I'd like to welcome the new BSMT president, Dr. Kate Templeton. Kate is a consultant clinical scientist specializing in virology at Edinburgh Royal Infirmary. And for those of you who are listening in or seeing tomorrow, Kate will be moderating the sessions in the afternoon. It's my pleasure to be able to welcome everyone to this meeting, and just to remind people that the BSMT will be hopefully holding a face-to-face meeting in May next year. So if you keep your eyes on the BSMT website, you'll find the details as they appear. I'm going to move on to my next slide. So that's my basic introduction and welcome to everyone. Just so that some information about how we're going to run the sessions. Apart from my introduction, each of the speakers will be introduced. They will then give their presentations. If you, as an audience, have any questions, please refer to the question section on the box and put your questions in there. As we proceed and get to the end of each presentation, we'll pull some of those relevant questions out. If, for example, we don't manage to answer all of the questions in the time we have, then we will make sure that there's answers on the website available to you later. So just trying to put this very important conference into context. Just over 12 months ago, the world changed for everybody, and especially for us in clinical microbiology and public health. Sorry, this slide. Okay, let's just go back. I'm sorry about that. Just thought it would be interesting to look at the history of respiratory virus pandemics in the 20th and 21st century, to get some idea of the scale of infections caused by these respiratory viruses. And in the main, respiratory virus pandemics are being caused by influenza A. And probably the most dramatic of these was what was called the Spanish flu epidemic. It didn't originate in Spain, believe it or not, but in 1918-20, and more than 500 million people worldwide were estimated to be infected, with a staggering death rate of 20 to 50 million people. So then in 1957-58, we had the Asian flu. Again, greater than 500 million people infected, and about 1 million people died. That was my first recollection of having influenza as a schoolboy. And then 1968, we had the Hong Kong flu. Again, similar numbers of cases and similar numbers of deaths. Unfortunately, obviously, my influenza immunity had waned at that point, and I got influenza again. It's an event one doesn't forget. And then the latest pandemic in the 21st century was the swine flu epidemic of H1N1 in 2009 and 10. And although I didn't get influenza this time, I was heavily involved in providing diagnostic services again across England with the Health Protection Agency. But again, if you look at the number of estimated people who were infected and you look at the number of deaths, they large numbers. And we'll come back to that in terms of context of COVID. So just a little bit about coronavirus infections. Is it a 21st century problem? Probably it may have been around previously, but we didn't have the diagnostic tools to identify it. But certainly this whole era started with SARS in 2002-04, with SARS coronavirus. Fortunately, there haven't been any cases of SARS-CoV infection since 2004. And then we have the emergence of the Middle Eastern Respiratory Syndrome in 2012, and there's still cases being picked up today. Probably this virus originated, but thought to be linked to camels, and is obviously therefore a zoonotic infection. And then, of course, we are all in the situation that we are now with COVID-19, caused by SARS-CoV-2 virus. This is currently ongoing across the world. It's a global pandemic in respect that it is moving around the world in waves. And the current estimate from Johns Hopkins is that there's about 160 million cases worldwide and 3.3 million deaths. Now that is still nowhere near the 2019-20 Spanish influenza outbreak. But of course, this outbreak is continuing. Looking at the evidence for some of these, it's quite intriguing that every one of these outbreaks of influenza has come in a series of waves. And that's exactly what we're seeing with coronavirus. So this phenomenon of seeing wave after wave should have been and was predicted by the modelers. Whether everyone listened to it is another matter. And the other thing I found interesting, in the 1957 influenza outbreak, office workers were advised to wear masks, and there are pictures online of people wearing face masks. So perhaps some of the preventative measures that we've seen in place in this COVID-19 outbreak, the history is already there to tell us what to do. In terms of the programme, normally we would have a single day meeting with 8 presentations. Because this is an internet presentation, a webinar, then there's 2 speakers. There will be 2 speakers on each of the afternoon. They cover many of the aspects of COVID infection, from laboratory diagnosis to the epidemiology to the sequencing. From a British Society of Microbial Technology point of view, this has been an absolutely challenging time for the technology companies, the challenges of developing sufficient automation and reagents to deal with diagnostics, the development of new diagnostics and their application, and testing in a different way that we would normally test for infectious diseases when we're not dealing with this sort of pandemic. There's been challenges with vaccines, there's been challenges with clinical handling of patients. And so across the board, there's been a huge learning exercise. And I hope that during the course of this week, some of that learning will be highlighted. Some of the difficulties, some of the controversial issues will be brought out, and hopefully that you will have plenty of time to ask pertinent questions. You might want to think, why have we got a section on secondary bacterial and fungal infections in COVID-19? And some of you may well have seen recently the articles coming from India on mucormycosis as a consequence of treatment for COVID. So the BSMT doesn't think of itself as a microbiology. For us is all embracing. It's bacteriology, virology, mycology. And the technology is driving us all closer together. So when we talk about microbial technology, we're talking about equipment, automation for use for diagnosis. So at that point, I would like to hand over to our first speaker, which is Dr. Michael Head. Michael began his career with a BSc in medical sciences at the University of Portsmouth and spent 11 years at UCL in the Centre for Infectious Disease Epidemiology and the Farr Institute for Health Informatics. Since 2015, he has been a senior research fellow in global health in the University of Southampton, with research interests in investment analysis, global health, health systems, and digital health, with a public health focus on neglected tropical diseases. So it's my pleasure to invite Michael to talk to us this afternoon as our first speaker. Over to you, Michael.
Good afternoon, everyone. Thank you very much for the introductions there. So yeah, my name is Michael Head. I'm currently recording this talk on the 6th of May. So hello to all of you in the future on the 11th of May. I'm going to be giving a talk a little bit about the global nature of the pandemic, along with some particular other topics that caught my eye. Thank you, of course, to the British Society for Microbial Technology for inviting me to speak, in particular to Mark Wilkes, who for some reason thought me interesting or important enough to put at the top of the conference. We'll see if he was right about that shortly. But regardless, pleased to be of service. I'm just going to now share my screen in that slightly awkward fashion that we are now doing with talks on Zoom in a minute. And I shall be clicking on the right button, and there we go. So there's my contact details there. If you do wish to get in touch, I am more than happy to share the slides. Now, I know that none of you were wondering about the Clinical Informatics Research Unit, which is Rome-based, so I won't labour the point, but basically a lot of data science, a lot of informatics. If you use the Edge software platform for your NHS-based research, and that's us, basically, Resin is one of my bits of work, looking at how to spend research money. I'm going to talk a little bit about that throughout the talk. So within the talk, it's a broad topic area, so I'm going to talk a little bit some aspects of current situation as of the 6th of May. Who knows what will happen in 5 days' time, but what's going on around the world right now. I'll be looking a little bit about one aspect of how the world was unprepared for a pandemic. I'll be talking a little bit about our COVID-19 research in West Africa, in Ghana and Togo. I've been working quite a lot with the media across the course of this pandemic. So a little bit on that, and also that will link into areas of misinformation and disinformation. Misinformation that kills, the not remotely Great Barrington Declaration, which alas has had a huge impact upon how things have unfolded over the last few months. So in terms of what's going on right now, this is what the world looks like at the minute. How is the world doing? Not very well currently. You can see that the confirmed cases per day is essentially as high as it's ever been. And we've got a tiny little downturn right at the end of the graph. Hopefully, please, let's hope that continues. But there is a lot of COVID-19 out there at the minute. And from the WHO situation report, well over 150 million confirmed cases. And of course, that would be a huge underestimate. It's entirely plausible. There's been about 1 billion cases of COVID-19 since the pandemic started. And there's also been 3.2 million confirmed deaths in just over 1 year. On a slightly brighter note, there's been well over 1 billion doses of vaccine handed out so far. But as we are seeing, although that's a lot, it's clearly not enough. This is from Our World in Data, which is a brilliant website. Do go and explore it. These are the highest daily rates as and when I looked at the website. And you can see a few countries of interest there. Sweden, this is the column to look at, by the way. But we can see that Sweden is still very high on that or league table, if you will, excuse the phrase, with high daily rates, and I think also pretty much overloaded intensive care units as well. It's been a pretty sorry story in Sweden throughout much of the pandemic, really. But also, I draw your attention to some of the Latin American countries. Latin America has had a huge burden of COVID-19 disease throughout the pandemic, probably most famously in Brazil, which has been perhaps highest profile, but across Central and South America, there's been a lot of COVID-19 there as well. And many outbreaks are out of control there even now. If you're wondering about India, their daily rates are high, not as high as some on that list, but they're high. But of course, I think it's fair to point out that data quality is not good coming out of India. We know that there will be far higher numbers than what is recorded. I think it is just a scale of the underestimate that we don't quite know yet in terms of cases and deaths. And that's where the UK is at the minute. At the minute, UK is in a very good place. We weren't 3 months ago, we are now. It's getting better. We're not quite there yet, but of all the countries in the world, for once during the pandemic, the UK looks a bit better than it did before. And this is what the UK looks like in terms of percentage of the population who have had at least one dose of the vaccine. We're going great guns here in the UK now that we've limited political interference, and Deloitte and Serco and co have stepped aside and actually let the grown-ups take charge. The people who know how to do vaccine rollouts, that's our health service, that's our public health authorities, other stakeholders as well. When that happens, then the UK can succeed with pandemic response. But within that obvious success, there's still things we need to look at. There's still inequalities throughout the pandemic and that are present within the vaccine rollout too. So you can see some of the ethnic minority groups there have much lower uptake than Caucasians here in the UK. So that's something we do need to address as we go forward. But back to Latin America, I think the Financial Times has done a lot of really good stuff during this pandemic around data science, around visualizations. And John Byrne-Murdoch, who's done a lot of that work, highlights how many of the Latin American countries have been suffering badly, looking here at excess deaths. And they are pretty high on the list in terms of lots of excess death. The UK is bad enough, but many countries are worse, including some of those in Central and South America. If we look at sub-Saharan Africa, though, the picture is not good, clearly, but it's not quite so bleak. So the number of confirmed cases is relatively low. Testing capacity, of course, is going to be very limited there, but there's no other real signals that Africa is experiencing a massive burden of COVID-19 disease. Deaths also remain pretty low. There's no real signals for sort of significant hospitalizations or evidence that health services are being overrun, unlike we've had here in the UK and many other countries like India as well are showing at the minute. And a paper caught my eye that was published in BMJ Global Health last week, as you were listening to it, on the 11th of May. And it covered the West Africa response. And essentially, there was a lot of evidence that lessons have been learned from the Ebola outbreak from a few years back in terms of their response to outbreaks, how to handle cases, how to clamp down on them early. And many African countries have put that into practice. And they've been able to manage their burdens quite well. And as you can see from my tweets on the left, particularly the bottom one, I think that those of us in the global north can actually learn a lot about outbreak response from the global south, and perhaps particularly across many parts of sub-Saharan Africa. We should be learning from them rather than the colonial type attitudes of the other way around. And a quick nod towards Japan, because it's Olympics year. Last year was Olympics year, didn't happen. This year is definitely Olympics year, we are told. But what's going to happen is we're going to have about 80,000 people coming from around the world, which is a scale back number, excluding the usual millions of spectators, for example. About half of that number are athletes, I think. The rest of it is add-ons, media, dignitaries, coaches, etc. Few of them will be vaccinated. A very small number will be vaccinated. There are no quarantines on arrival apparently required, we are told. And these people are quite literally coming from all corners of the world, everywhere in the world. Will be descending upon one city, Tokyo, during a pandemic. And then about 3 weeks later, they'll all run back home again with possibly some new virology-related souvenirs. I just don't think this is going to be a good idea. I've been quoted in the press in a few places saying that there's nothing about the Olympics that makes any sense whatsoever right now. I think that comment was from a few weeks back, and that still remains my view. I don't think it's a good idea to have the Olympics this year. The Japanese public don't particularly want it either. Every time I've seen a poll on this topic, this is the sort of number that we see. About 3/4 of the Japanese public think it should be postponed or cancelled altogether. So I'm now going to move on to a bit of my research because it's my talk and I can. So this is perhaps a different angle to what you might have seen before when it comes to sort of looking at how we got to where we were and our lack of preparedness. We in the global health research world are reactive. Funders, researchers, policymakers, it's all reactive stuff. My project looks at spending on infectious disease research globally around the world. So our data set covers $105 billion of research across this 18-year time period from 2000 to 2017 inclusive. And this is a paper we published in The Lancet last October, October 2020, for those who are interested. This was one of the slides, one of the images from the paper. So you can see that since 2006, funding has been declining for infectious disease research, which is probably reasonable on the whole because non-communicable diseases are on the rise and infections are coming down. But pandemics and so on, we have been caught cold with that. And we've been caught cold before. Overall, within our $105 billion, 0.4% was spent on coronavirus-related research. And you can see that pretty much all of that research was A, preclinical in nature, so still quite an early stage of the research pipeline, but also clustered around and just after the outbreaks of note, so SARS and MERS being the key ones. And then before and after the funding declines. So we are reactive to the public health emergency. When the emergency stops, we forget all about it. Similar with Ebola, not a lot of funding ahead of the public health emergency in 2014-15, and funding declines rapidly soon after in terms of the research. Little horizon scanning going on. Zika, even more stark, we'd never heard of the word Zika really until 2016. And all of the funding is gathered around the years of the outbreak that started in South America. One of the other things we looked at within our work is we look at level of funding compared to the burden of disease. So this is looking at disability adjusted life years. And if you see on the bottom right hand corner of this graph, excuse me, you can see that pneumonia is pretty underfunded compared with burden of disease. So again, we've been caught out a bit by not focusing on some potentially high burden areas. Well, there are high burden anyway with pneumonia, but when pandemic viruses come along that cause pneumonias and many more things besides, then we don't quite know what to do about it. And part of the reason for that is a lack of knowledge from previous research. So we in the global health world are reactive. We pump we pump money in when there's a problem, not before. A proactive horizon scanning approach about what's coming next is crucial, in my view. We have organizations like CEPI, which is great. I think we need a few CEPIs around the world, really. Preparedness is key. That includes research, and equity is lacking. We need huge investments and a focus on low and lower middle income settings, including research and infrastructure to scale up the products of research like vaccines and diagnostics and so on. Now, moving on to another bit of my research, which I hope is kind of useful in terms of reflecting some of the global problems, looking at Ghana and Togo, West Africa. These are the flags of those countries. And just to orientate ourselves, these are where the countries are, just north of the equator in West Africa. We've done a few things, one of which has been population surveys looking at knowledge and attitudes to COVID-19. And you can see from the top bar here that most people have got the hang of COVID-19 and that they know it's a severe illness transmitted between people. We did put in some other options for them, but there is a certain amount of misinformation within that. Conspiracy theories are rife all around the world, and West Africa is no exception there. We did similar in Togo as well, and similar results. So most people know roughly what COVID-19 is and how it transmits, but again, there is a certain amount of misinformation around sort of biological weapons from China, a virus deliberately designed by the pharmaceutical industry, and so on. And 5G is also a prevalent conspiracy theory, particularly in Ghana, actually not so much in Togo, but it does exist there in those countries. We also looked at willingness to vaccinate. I'll come back to Ghana in a minute. This is Togo from our survey in January. About a quarter of respondents said they would not get vaccinated when one becomes available. And when asked why, the key reason is that issues around safety. So hopefully this is information that can be useful to the Togo government in terms of tailoring their messages. We are going to set up another survey just to go a bit deeper into some of these viewpoints, just to get something a bit more precise about who they do and don't trust, and where the willingness to vaccinate is lower, just so that we can help direct. We'll give some information to the Togo populations to direct their own public health response a bit better. We've done that within Ghana. We just published this report. The Togo one will follow, but this is new coming out of Ghana. So in August, the first survey, 62% were willing to be vaccinated. That's before any COVID-19 vaccines were approved. March 2021, this is just after some AstraZeneca vaccines had arrived in Ghana, and 80% were willing to be vaccinated. At that point, we will do a third round to assess the impact of the recent reporting of adverse events, particularly around Johnson & Johnson and Oxford AstraZeneca, which will be key weapons to underpin the pandemic response in low-income settings. And so with that in mind, I don't think the constant undermining here in the global north of the vaccine rollout, particularly around those two vaccines, has been helpful. And it may well have repercussions in the global south, who see us rejecting the vaccine to some or greater extent, and they therefore not wanting to have our cast-offs, have our duff products, if you will. So we need to be careful about this. It is a global problem. We need to treat it as such. We're also looking at some self-reporting measures from mobile phones as a possible early signal of outbreaks. Most Ghanaians have a mobile phone, but not necessarily a smartphone. But can we use this technology to encourage self-reporting of COVID-19? And can we detect outbreaks earlier on than normal? And ultimately, can we use this for future emergencies, future outbreaks? And if there are issues like sort of famine or earthquakes, can services like this be useful to highlight areas of urgent need? This is what the system looks like. It's a Ghanaian-led and owned platform called Opine World, and people can dial a number for free of charge, and answer questions like, are you coughing? 1 for yes, 2 for no, and so on. And then this is not actual data, this is example data. This is kind of the back end of the system, so you can see what people are answering and roughly where people are answering from. So if you have districts that are reporting large numbers of possible COVID symptoms, then you can target your public health resources accordingly. That's the theory. This is a feasibility study, so we'll see what comes out of that over the next couple of months. And coming soon, we're going to do something looking at long COVID in Ghana. We've got working with Ghanaian partners in the health service and the universities to look at a few thousand confirmed COVID-19 patients, to look at any prevalence of long COVID and issues around stigma and mental health and well-being as well. That's going to start in the next couple of months, hopefully. Now, I have been working with the media a lot during the pandemic, and it's been interesting. It's been quite good fun. I think overwhelmingly, if you've got the title of health or science correspondent, then you are very good at your job. I think the media reporting is actually, the articles themselves have been pretty good. Some of the headlines have been shoddy. The occasional bad article and bad journalist is in there, but overwhelmingly it's been pretty good, regardless of their affiliation as well. And we all have media outlets that we hate. Maybe it's Fox News, maybe it's The Sun or the Daily Mail. They're certainly mine. But I've spoken with journalists from the Mail, the Sun, the Express, and they've all been very, very good to me. They're treating me well, and I think they've been putting out responsible coverage. The headline writers, not necessarily so, but the journalists themselves, I think, are doing a good job. Dealing with the media can be a very different way to spend your days. This is a slight tangent, so bear my indulgence here. This is me feeding the fish in my pond in the back garden, which is just over there. At the request of the local news, I don't think I gave a very good interview here, because I spent the interview thinking that he wants me to feed the fish in a minute, and I didn't really concentrate on the questions. So I think the feeding of the fish was a particular highlight from that interview. But I was also particularly thrilled about this. I did an interview on the BBC, and I got reviewed by the Bookcase Credibility Twitter feed, who looks at your backgrounds and passes comment on them. And I was thrilled by this. It was so exciting. And if you think, well, is that really is that particularly important? Then, oh my word, yes, they've got a big Twitter following. They really have. So yes, this was very important indeed for me. It's the sort of thing that just brightens up your day a little bit, I'd say. But slightly less flippantly, in terms of things that get into the media, there's misinformation out there. I know the media, on the whole, it's been good, but there's some really high-profile bad bits. And the Great Barrington Declaration is possibly kind of the leader of all of that. Talking a lot about naturally acquired herd immunity, which initially was reported in some places as a split between scientists. And I disagree with that. I think the consensus was always pretty clear that this was a bad idea. And just a few outlier, alas, high-profile scientists were promoting this view. This is an illustration that I've knocked up just for the purposes of this particular slide. Most of us commenting on the pandemic, I think, are somewhere in these dots in the middle. We disagree with each other a bit, sometimes bitterly so, actually, I think, when most people are actually normally roughly on the same page. But we're all in the similar ballpark. But it's these outliers that are the problem. They're certainly not on the same page. They're not even in the same book. They're probably writing their own book, especially for the anti-science crowd ahead of a speaking tour next year, is my guess. But regardless, they're interesting to report on because they're different. But ultimately, they're not useful for good policy or practice because they're not really going to be right. They're well outside the consensus viewpoints. And many institutions, groups, individuals pointed out that this was unethical. The WHO said it was scientifically problematic and unethical. And Great Barrington Declaration fans have now moved on, well, still going on about herd immunity, but also now going for anti-vax messages as well. This is from the Great Barrington Declaration website. I went and looked it up so you don't have to. Hope you can thank me for that. But again, they talk a lot about herd immunity there on the website, even though in interviews they now claim it's nothing to do with herd immunity. And those are some of the key individuals who've been leading it. There was a strong rebuttal everywhere, including this article in the Lancet, a very good one, pointing out that it's a dangerous fallacy unsupported by scientific evidence. And that is very much true. The academics involved make wild claims, such as "I've been silenced," claim many of them, including Carl Hennigan from Oxford, who's had a really pretty bad pandemic in terms of good public health information. He claims that he'd been silenced, and he claimed this on national radio, on, as it goes, Julia Hartley-Brewer's programme, who many of us will know as one of the bad journalists doing a very bad job at reporting responsible messaging here. If you don't know who Julia Hartley-Brewer is, then I'm sorry for ruining your day about that. But they have high-profile platforms. They've not been silenced. Hennigan and Gupta and others had an actual audience with the actual Prime Minister of the United Kingdom. That's how silenced they've been. They only get to meet the Prime Minister. And they also get to the White House as well. Under the previous government, I would suggest, I don't think Biden has got any time for them, I hope. Certainly whilst Trump was in charge, then these scientists had not just a foot in the door, they were invited to the table. So they are not silenced, and they have influence as well over policy and practice. This is not a good thing. There's a vaccine being rolled out now, or there's several vaccines, and you would hope that their claims about reaching herd immunity and just letting people go about their daily lives and letting the virus just run through populations, you would hope that vaccines would be a good thing for them. But no, they're now going for the anti-vax votes as well. Hennigan hangs around with anti-vaccination scientists. He has done for years. The various people I mentioned so far are now to set up different groups, which shape-shift into different names every 20 minutes. One of them was called Panda. And as you can see from this box, they put out reports with sections called "Vaccines are inherently dangerous" and things like that. There was another group called Heart, which basically did similar things, with some of the same names, some other ones as well, including David Livermore, who has a long career looking at antibiotic resistance. I've seen him speak a few occasions. He was very entertaining, very knowledgeable. I learned a lot, but sad to see experienced colleagues like him going down the rabbit hole of anti-vaccination messaging and bad public health messaging during a pandemic. It's not good. It's very sad to see. So ultimately, the views of these people are dangerous, and they're undermining the whole worldwide response in trying to deal with the pandemic. And herd immunity has definitely not been reached in India. It's pretty obvious that it has not been reached, despite claims from others, including Great Barrington Declaration fans as well, who said in January this year that vaccinations are bad and that natural herd immunity is great, including in India. And then you get messaging from the politicians. So Modi, the president, has the country's leader has been encouraging people to mix and saying that the pandemic's over. The health minister said that India was in a pandemic endgame. And alas, the upshot of that is scenes like these. There's so many stories coming from the ground of people burning bodies in the street because crematoriums and graveyards are full. It's heartbreaking. It's a humanitarian emergency. And contributory factors to this happening are some of the words coming from scientists who should frankly know better. So it's a bit of a whistle-stop tour. Sorry if some of it was a bit bleak, but I think really that's where we are right now with the pandemic. Globally, it's at its worst point than at any point in the world, any point in the last 12 months. So great care is going to be needed over at least the next 12 months. I think we will see more countries exhibiting outbreaks a bit like India at the minute, as vaccinations are slow to reach many settings. We must urgently get more vaccines into arms in resource-poor areas. That is an urgent need. Naturally acquired herd immunity as a strategy is demonstrably a stupid idea. It really, really is. But let's finish on a positive note. Vaccines are great, aren't they? Vaccines will underpin the way out of the pandemic, and good science, of which there are so many examples. The genomics, the microbiology, the diagnostics, the clinical trials that tell us that dexamethasone is useful at times and that hydroxychloroquine is just a Trump fantasy. The behavioral scientists, the social scientists, so much good stuff out there, which is all coming together to help us get through the pandemic. But there will be some tough times to come. But ultimately, we are going to get there at some point soon. I'm going to leave it there. Thank you for listening. Those are my contact details on the screen again. I will now stop sharing my screen. I'm now happy to fast forward to the present day and take any of your questions. But thank you very much indeed.
Michael, thanks very much indeed. That you've covered a huge amount of areas of coronavirus infection and some of the challenges of handling huge amounts of epidemiological data. We have a couple of questions. Just a second. The first one is, just a second, I'm just trying to get my question box open. Can the relatively positive picture from sub-Saharan Africa be attributed to lessons learned from Ebola outbreaks, which maybe only impacted a relatively small region in Western Africa? Or are there likely to be other factors at play? And is there a significant variation in rates across Africa?
Yeah, that's a fair point. And the paper that I cited in the slides was focusing on West Africa. But I think across the continent generally, it doesn't appear to have suffered too badly, because a lot of countries did put similar measures in place early on, including border closures was a key one. So they restricted numbers coming into their countries, and they were able to handle whatever outbreaks they did have a bit more easily. I think one thing we can learn from the continent of Africa that we don't do very much of here in the UK, and probably across many high-income countries, is the really community-focused approach to healthcare, where often you are taking healthcare to people's front doors, and there is that strong link between community healthcare workers and their populations. Whereas here we often have sort of go to our GP, whereas in places like rural Ghana, for example, again, medicines are sometimes brought to your front door, and there is that much more community feel. So there's that trust there. Healthcare is delivered in the community. And I think all of that is a helpful contributory factor when it comes to managing urgent situations like outbreaks. Clearly, there will be many, many different factors at play, and it doesn't apply across a large continent like Africa. And we've seen countries where rates have been high, like in South Africa. And also, was it Tanzania that for a long time claimed it had no COVID cases at all and wasn't bothering to count them until its leader died a month or so back, possibly from COVID-19. And I think the new president, or whatever the title is, I think it's president of Tanzania, is now sort of done a bit more responsible public health stuff since they got put into power. So it's hard to sort of judge Africa too much, but I think the signals we're seeing in terms of their burden of disease and some of the pandemic responses, given their limited resources especially, I think they've done pretty well so far. But of course, as we're seeing in some countries around the world, like India, like Nepal as well, that so far is quite a key caveat. The pandemic is still burning brightly, and there's a long way to go yet.
Thank you, Michael. Another question, which relates to the reporting of excess deaths, which was in one of your slides. Are all countries now using the same criteria for reporting excess deaths? And therefore, are the results comparable?
They're almost certainly not using the same criteria for excess deaths. And that was something that, again, John Burn-Murdoch highlighted in his Twitter thread. It is well worth a read. So again, with any data set that's comparing multiple countries, caveats within that, data will unfold over time. The UK is actually pretty good with its reporting around deaths. The Office for National Statistics, has again done a sterling job in terms of some of the number crunching and data reporting during this pandemic. Other countries do lag a little bit in terms of their death reporting, or don't really report it at all very well. Again, we're seeing lots of reports from India of undercounting in terms of their daily numbers, but also bodies being burnt in the streets on pyres and not necessarily ending up on any official kind of death count list. So there will be a lot of reviewing of data once the dust settles after this pandemic, for sure, to get kind of a more informed idea as to which countries suffered the most. But data as it stands at the minute, I think certainly some of the Latin American countries aren't looking in great shape, and the UK has well over 150,000 deaths. It may well be up to about 200,000 by the time we end the pandemic, once we kind of go back and look at deaths that weren't classified as COVID-19 at the start, which is a huge toll. But alas, it may not be anywhere near the kind of worst toll based on various metrics, one of which is excess death.
I just received another question, Michael. Sorry, a text message. What lessons for other infectious diseases, especially TB and malaria, in which progress has been incredibly slow? Are there any lessons for diseases like TB and malaria, in which progress has been incredibly slow from the work that you've been doing?
I think for malaria, rates have come down a lot over the last 20 years. So although there's still plenty of it, and we must do better, I think where we were at the turn of the century with malaria, I think we're doing much better. So we got some interventions that we know work. We know that bed nets are a very, very effective intervention, and there are therapeutics that are effective, and there is a vaccine that is coming on board, and there's certainly a lot of research around vaccine development for malaria. So I think for malaria, the picture is fairly bright. Tuberculosis, yeah, that's another one. That's a tricky one, isn't it? Because tuberculosis has been around for thousands of years, but we've still got over 1 million deaths per year from tuberculosis, and we'll need to see what the effect the pandemic will have had on some of the high-profile infections like TB and malaria and HIV and so on. I think certainly strengthening health services will be one key aspect to ensuring that preventable diseases like TB and malaria are managed better. So I think we do work in our silos. We do work in malaria or TB or in cardiovascular disease. I think kind of a joint approach looking at health systems research that incorporates all of those areas would probably be beneficial, particularly as there are such limited resources to spend on research and limited resources to spend on healthcare. So I think various innovative approaches, maybe even around areas like telemedicine and digital health used appropriately, could benefit all diseases, including TB and malaria. So I think those are probably some of my kind of immediate thoughts on that particular question.
I've got another question, Michael. Obviously, with the emergence of COVID-19 and the interventions that have been put in place, there's been a huge and dramatic decrease in infections with other respiratory viruses. Do you think there's going to be any backlash from that in the next couple of years?
Yeah, it's a good question. It's one the media occasionally asks me, and I don't quite know how to best answer it. I think I'd be quite keen to, over the course of this whole discussion, not necessarily right now, but hear from some immunologists about our immune memory and things like that in terms of circulating respiratory viruses, which is not an area I know anything about. So it's possible that we might have if we are mixing here in the UK, for example, over this winter, which it looks like we probably will be, we certainly can expect to see a bit more COVID-19 around, and we probably can expect to see possibly normal levels, just use the phrase, of flu. Will it be a bad flu season simply because we didn't have a flu season last year? I genuinely don't know the answer to that. It's something that does need some thought, but that definitely does need some thought from probably cleverer people than I who know more about the viruses and the immune system, I think, just to kind of add a bit more context to it.
Oh, Michael, I think on behalf of the BSNT, I'd like to thank you for your presentation. It was quite thought-provoking in a number of areas, and I think you've been honest with us with your views, and that stimulates us all to think, and not just to accept the stuff we read either on the web or in the newspapers. Thank you very much for making the time last week to prepare this and record it. And just before I let you go, I just want to remind the audience and the registrants that the links to today's recordings will be sent to each of you later today. So if you want to then share that with other colleagues, you can. But Michael, on behalf of BSNT, thank you very much indeed for a stimulating presentation.
Thank you very much for inviting me. Pleasure to give this talk.
Thank you. So we'll be reconvening at 3 o'clock at UK time with our next speaker. I'll introduce him at that point. Thank you.